Vivian Olusaka is a mother of one, her son Quinton. Quinton was born at 38 weeks through a cesarean section delivery, a bouncing baby boy of 2.8 kilograms. Vivian was all too happy as a first-time mom. All was going on well for Vivian and her son Quinton up until he was 2 weeks old. Her son would add grams, if any. Vivian thought this was normal. Afflictions from exposure to cold. She tried to dress him warmly, but no, the young boy would not improve. The clinicians whom she visited thought her son was malnourished. By this time, Vivian had quit her job to raise her son. The news of an expensive surgery to save her son's life was devastating. She had no money. Her journey from hospital to hospital, including being referred to India for a cheaper alternative, began. Her luck came knocking through a WhatsApp group where one of the members also had a child with heart condition. They shared their findings, including one that MP Shah would be hosting a group of doctors from the United Kingdom whose goal was to heal little hearts like her son's. She was not going to pass this golden chance. When she was called to come in for the surgery, Vivian could not believe her luck. Her son underwent a successful open heart surgery in November 2018. Other than that, Vivian was all too happy to go home with her baby. Despite his delayed milestones, Vivian knows that his future is as bright as any other child his age.
Quinton's story is a story of Michelle. It is the story of Yaris. It is a story of 500,000 other children in Africa born with congenital heart diseases. Developed countries have made significant strides in addressing these birth defects, but Kenya, like other developing countries, are still lagging behind. We talk to Dr. Salim Jivanji, an interventional cardiologist working in the United Kingdom and part of Healing Little Hearts Kenya, a mission that visited MP Shah Hospital to offer open heart surgeries and cardiac catheterizations to repair various types of congenital heart diseases.
I like cardiology as a career, but interventional cardiology, particularly in congenital heart disease, allows you to see every single subspecialty in pediatric cardiology. So I say pediatric cardiology because it's mainly congenital heart conditions, which is what pediatric cardiology is about. But with interventional cardiology, first you can see patients which have pulmonary hypertension, which is a subspecialty in itself in Western countries. You see patients with structural or congenital heart conditions, which is not a specialty in itself, but it's a condition that people specialize in. You become very good at imaging, so that's another specialty in itself. You are able to interpret information which improves your practice. And also you have, I enjoy the technical nature of doing very high technology and highly advanced procedures. And the outcomes, the transformation of life is quite amazing. Broadly speaking, very broadly speaking, there are three sort of types of heart conditions. One is, or actually two. So one is congenital heart, which is something that you're born with. And then the other one is acquired. Acquired heart conditions are one that you acquire through the process of your life. So it can be either an infection, it can be as part of your lifestyle. So if you're sort of overweight and eating high cholesterol food, then you'll be subjected to having conditions like atherosclerosis, which is blockage of the coronary vessels. But that's not something that we deal with. Our focus is congenital heart and sometimes acquired or heart conditions if they are relevant in terms of treatment. The most common one is ventricular septal defect. There is atrial septal defect. There is patent ductus arteriosus. These are the most common ones. I'll come to that in a second. The ones that we see here in our trips, common ones are tetralogy of Fallot, blockages of valves like pulmonary stenosis, aortic stenosis, blockages of some vessels like coarctation of the aorta, and then there are much more complex conditions which I can go on about, but I think this one probably covers about 70-80% of them. So a hole in the heart usually means a hole between the chambers of the heart. So an atrial septal defect that I talked about is a hole in the heart. A ventricular septal defect is also a hole in the heart. So an atrial septal defect is a hole between the top two chambers of the heart, which are the collecting chambers, and a ventricular septal defect is a hole between the two pumping chambers. So the right side of the heart and the left side of the heart, although it's part of the one organ, almost work independently. And if there is a hole in it, then you have a mixing of blood, and hence you have the symptoms. Whenever we see a patient with a congenital heart condition, the most common question from the parents are, have we done something? Is it something that we could have done to prevent it? But actually there is no clear reason, there is no clear understanding why it happens. There are very few conditions which are associated with certain medications that you take with pregnancy, but those are extremely rare and it's well publicized. And if you're getting treatment by a medic, then they should be aware about them, but the vast majority of them, more than 95-98% of them, we have no idea why it happens. So there are various different things to look out for. It's interesting because it's the kind of thing when I give advice in the UK, it's very different to what I see here in Kenya. We've seen patients really late. We've seen patients which have come in about 10 years of age, having had a heart condition and the family have never known about it. But the kind of things to look out for is breathlessness is very common, getting tired all the time, turning blue. So if you're doing a minimal amount of exercise, the color changes from being pink to becoming quite blue. Not growing very well. That's a very non-specific finding, but if everything else is going fine in terms of they're feeding well, they're doing well, then if they're not growing well, they're not putting on weight, then there should be a suspicion that something might be wrong. But this is just things that parents find, and usually visiting a doctor, they should be able to pick up certain signs from the doctor to be able to point that there may be something wrong with the heart.
Do all these symptoms occur at the same time, or do they have an age difference, such that if the child is a newborn or still within 1 year, they have different symptoms as opposed to an older child?
The condition is, so it depends on the condition. If you have an atrial septal defect, for example, you might not see any symptoms until well into your 50s, 60s, if any. If you have a ventricular septal defect, depending on the size of the defect, if you have a very tiny defect, you have no symptoms. If you have a small to medium-sized defect, you might see symptoms in the first 4 or 5 months of life. If you have a very large defect, you might see the symptoms literally after birth. So it really changes depending on the condition you have. So if your child is born and is completely well in the first month of life, and then about 4 months of life starts becoming breathless, that doesn't mean that the child does not have, because he was fine before. In the same way that if you've gone through life and you have something happening at about 15, 16 years of age, it depends on what the issue is at the time and what the symptoms are. There is no specific age in terms of when you have the symptoms. The vast majority of them, you will see them early in life, within the first few months of life. Patients here are very sick, the ones that we see. So I give an example. We saw a patient in our last camp who had a condition known as pulmonary stenosis, which is a blockage of the vessel which goes into the lungs. It's a very common condition that we see in congenital heart disease. Picked up very early in life, usually in Western countries, sometimes even before birth. And within the first few months of life, particularly in Western countries, you picked up 99% of them. Whereas here, we saw a patient who was 10 years of age, had very severe pulmonary stenosis, and was barely able to walk even 10 meters. And when I was taking the history from the family, I said, what is the reason why it's taken you so long? They only realized there was something wrong with him a year before that. And the reason why they didn't really think that anything was wrong with him, they just assumed that this is what he was like. They just assumed that he's a quiet boy who doesn't like playing. And they never realized that there was actually something wrong with his heart. They only realized after he was getting exhausted and his tummy started swelling. And they realized that there's something wrong, so they got him checked out with the doctors and found out that he had quite severe pulmonary stenosis. There are certain conditions which are associated with congenital heart disease. So the vast majority of patients, like we see, I would say, have no associated symptoms. It is just an isolated finding. But there are certain syndromes. For example, if you have Down syndrome, there is a 50% chance of having a congenital heart problem. There are other conditions like CHARGE, there's other conditions like Noonan's, Turner syndrome. All of these have associated heart conditions. So if we see a child with a Down syndrome, then we have a very low threshold of checking that whether there's something wrong with their heart. Similarly, if we saw a child with a certain kind of heart condition, we would then be querying whether that child has a certain syndrome, because they're often associated together. But the vast majority of congenital heart is isolated. The most common things that we see, I've told you about the symptoms that the parents should look out for. Those are the questions that we'll be asking anyway. But we look at their oxygen saturations, if they're getting a good amount of oxygen in their blood. If they don't, then we try and find out what the reason is, and if it's whether the heart or whether it's the lungs. We look at their growth, we look at their weight. Those are the basic, parameters that we look at initially. And then on examination, we see if there are signs of a heart condition, whether they have a murmur. And I'll come back to that in a second. Whether they have an enlarged liver, whether their heart is looking very dynamic, whether he's got an unusual sound. And if it does, then the next step we would go to is identifying what the issue is, and that's usually by doing an echocardiogram. An ultrasound examination of the heart. So we use specially designed machines which are calibrated for us to look at the heart. It sends Doppler and sound signals to the heart where it reflects back, and it forms a picture of the heart in terms of what it looks like, how it pumps, and you can see it live as it's pumping the chamber. And the modern machines, you have some really, really clear pictures in terms of what's going on. So you're actually seeing a picture of the heart. The families can see the heart pumping as we're looking at stuff.
Can you increase the suction a bit, please?
The cheapest method is an echo. The cheapest, the least invasive, and the one which is used throughout the world is an echo. An echo machine, there are modern echo machines which are as big as a laptop. And hence, local cardiologists in Kenya have satellite clinics across Kenya where they take a laptop kind of echo machine and go and do scans in various different parts of Kenya. And then we have larger machines which are much more advanced with very high resolution, which are usually housed in hospitals. So in fact, in MP Shah, we have both different kinds of echo machines. So a lot of parents get told that your child has a murmur. And there's a huge amount of panic. A murmur is a sound that blood makes as it travels through the heart. So anybody can have a murmur, but if you have a murmur, it can suggest that you have a heart condition. Certain kinds of murmurs are very specific to certain heart conditions, and there are softer murmurs which are quieter, which are more difficult to identify. But it's usually a spectrum of different conditions. If I saw a child with a murmur and everything else is completely normal, and the murmur is very, very soft, and it changes in sound depending on the position of the child, or it sometimes becomes quiet, then it's unlikely to be of anything to be concerned about. But if I saw a child with a loud murmur and looking very small and breathless, and the color is not right, then you know that there is something likely going to be wrong with the heart. If you have an enlarged liver because you have a big hole in the heart and your heart is struggling to pump blood in the appropriate manner, once you correct it, it usually goes back goes back to normal after 4 to 6 months, sometimes even a year. If you have a heart condition where you have a severe blockage of a vessel, and as a result of that, your pumping chamber becomes really quite thick, and it changes in terms of how it pumps blood. Sometimes your liver never completely recovers in terms of becoming a smaller size. But usually the vast majority of patients, they will, once you correct the heart condition, you dramatically improve everything else in the body. So on average, we do about 2 open heart surgeries, and we do about 4 catheters a day. So you're looking at about 6. So you're looking at about 25 to 30 in a week. So then you have about 40 patients which we can't do anything for. How do we decide which one to pick? That's the difficult choice. We try and choose patients on clinical basis. We try to help out the ones who can't afford the care. We try and give those patients priority, because the ones who can afford care, they can go and seek help from the local cardiologists who either do the procedures in Kenya or arrange for them to go overseas. We look at clinical status in terms of, if we don't do something for this patient, what's going to happen? Are they going to become sicker? Are they going to survive? Are we going to transform their lifestyle? So that's the criteria that we use. So we don't, if we have a patient which comes on day 1 who's number 1, doesn't mean that he goes number 1 for surgery. We look at all the patients in the first, so we have a clinic learning in the first 2 days. We look at all the patients who are coming in, and then out of the ones that we have, we then sit down as a team. Like on Saturday, we spend 7 hours discussing every single patient, and then lining them up and listing them accordingly. And then we have a wait list. Sometimes you have a patient which gets cancelled for a different reason, and then we would take somebody who's on the wait list. About 45 years ago, every single heart condition was done by open heart surgery. I would say about 30 years ago, I would say maybe 85% of heart conditions were done by open heart surgery. I would say last 20 years, it's probably split now. And the reasons are various. The technology is advancing quite quickly. The equipment and the devices and everything that we have are significantly advanced, and that there are certain conditions which are done by open heart surgery, we can now do it via keyhole. So for example, if you have a blockage of a vessel, like we had one yesterday, you can do a cardiac catheterization, take pictures of the heart by injecting contrast, which is like a dye, have a look at it on X-ray, and you're going inside the heart with specific special catheters, measure pressures, and then once you've decided, you choose the appropriate size balloon and stretch the valve open. As early as about 20-25 years ago, that was done by opening up the chest, putting the patient on a bypass machine, which is stopping the heart, opening up the vessel, removing the blockage, and restarting the heart. So open heart, for example, tetralogy of Fallot, which is a common condition that we're seeing. If you have a small child with coarctation of the aorta, which is a blockage of the vessel supplying blood to the body. We've got a child who has a very large ventricular septal defect. So we've got a 1.5-year-old we operated on last night, who was only 4 kilos. So there should be about 12-14 kilos, and the child was only 4 kilos, the size of a newborn. So we operated on that patient last night. So it depends on the size of the defect and where it's also positioned that you decide which pathway they're going to go ahead for. So I think the simple answer is that there are certain conditions which does not have the technology of doing it via keyhole, which is cardiac catheterization, so they still go via open heart surgery. Certain conditions which have a better result via open heart surgery, and hence they would go for that. And there are certain conditions which we would easily do with cardiac catheterization. It also depends on what team you have available and what equipment you have available as well. For example, in cardiac catheterization, we've got patients which have got patent ductus arteriosus, which is a connection between the two great vessels. We have pulmonary stenosis, which is a blockage of the vessel going into the lungs. We have atrial septal defects, which is the hole between the two top chambers of the heart. Some ventricular septal defects, which is the hole between the lower chambers of the heart. This is the condition that we're working on in Kenya. But in countries like the UK and Western countries, you can even implant a whole new valve via cardiac catheterization.